Morning, and thank you so much for being here. I am State Senator LaTanya Johnson. I represent the 6th Senate District, and it is such an honor to have you here celebrating the second week of Black History Month with us. We are going to have a roundtable discussion with Wisconsin state agencies. In this 2021-23 state budget, Governor Evers and his administration and the other state agencies prioritized the health and mental health and overall well-being for families here in Wisconsin, and also for the students and communities. Today, we will hear directly from these state agencies and departments about how they prioritized investments to improve the health and well-being of African American Wisconsinites in their budget request, what they see as major challenges to addressing these disparities, and what they hope to accomplish within their agencies to improve the outcomes for the African American community today and also for the future.
Nice to see you all, and thank you for having me, and thank you for the grace to let me join a key meeting here and dial in just a little bit in progress. So I am super happy to be with you and really pleased to share a few highlights of both the governor's proposed budget from this current biennium that we're in. Appreciate the chance to take a little walk down memory lane and talk about what we thought was important then that we still think is important, as well as touch on some really important questions that your office shared, Senator, around certainly the COVID-19 response and the overall state of health and well-being for Black families in our state. So great topics. Let me talk quickly so we have plenty of time for dialogue. So first, when it comes to the question of how did we in the Department of Health Services, working with our colleagues in the governor's office, how did we really center health equity and what is in the best interest of Black families in our state, Indigenous families, Hispanic families, other communities of color? Couple of things to lift up. First, in the space of maternal and child health equity, we know that Wisconsin continues to be a state with wide disparities in both maternal and infant mortality, particularly when we look at the differences between Black women who may die in childbirth and what happens to Black babies who may die before their first year of life. So we have a maternal mortality rate that is 5 times higher for Black mothers in our state than it is for white mothers. We have an infant mortality rate that is 3 times higher for Black babies than it is for white babies. And those things are unacceptable. And those are trends that we absolutely have to close those gaps and we have to reverse those trends. So in order to do that, the governor proposed extending postpartum coverage in our state Medicaid program for a full 12 months, which is in fact what the Centers for Medicare and Medicaid Services recommends. Currently, women retain that Medicaid coverage for 60 days. What the legislative majority opted to do is extend that coverage to 90 days, which is a step in the right direction, but it is not the full 12 months. In addition, the governor recommended that we begin to cover the services of certified doulas in the Medicaid program. Again, we know that doulas can provide great support to pregnant and birthing people, and we would like to be able to extend that as a Medicaid benefit. We also sought to extend additional funding in the Women's Health Block Grant to make sure that we can do good preventive screenings for cancer, sexually transmitted infections, provide additional contraceptive services, and related care. In the space of mental health, when it comes to equity, we know that we want to be thinking here about equity based on race and ethnicity and primary language. As someone said to me the other day, imagine going to a therapy appointment and having to share your thoughts and concerns first with a translator and then with your therapist. So we have a lot of work to do in that space. And mental health is also an area where we have a lot of work to do in geographic equity. We know that it is not easy to find access to mental health services in some of the more rural parts of our state. It's not easy to find access to mental health services in some of our more densely populated parts of our state either, just due to demand. And in addition, we know just based on the evidence of the high number of crisis calls and short-term admissions to, in particular, Winnebago mental health. We know that that is evidence of a failure of upstream and more preventive mental health services. We're not getting to people soon enough. And so the governor proposed some investments in mobile crisis teams, particularly support for Milwaukee County, as well as additional crisis support in other parts of the state. We also proposed creating a new type of mental health crisis provider so that we could have more opportunities for law enforcement who may be dealing with someone in a mental health crisis to have a screening and a treatment and a stabilization facility that they can take that person to without requiring a transport to Winnebago mental health. Those proposals did not move forward in that format. We do have a proposal now in front of Joint Finance to release $10 million that could be invested in mental health crisis funding to really extend those services. And we're optimistic that that will move ahead, and certainly we'll revisit that more comprehensive proposal we expect in the next proposed budget. In addition, I will spend some time in just a minute talking more about what we all have come to know as the social determinants of health. So housing, income, education, access to healthy food, safe communities, good transportation, all those things roll up to how long people live and how healthy they are while they're alive. So in order to ensure that we can do our best work locally and really respond to local conditions, the governor also proposed a package of health equity community grants that would have really supported planning at that local level and identification of what those most pressing concerns were. In addition, many states now are beginning to use their Medicaid programs to invest in housing supports and connectivity to food assistance, transportation, again, all the things people need to be healthy, because evidence is showing us that when you support people in those other kinds of needs, their health improves. And so the governor proposed a community health benefit in the Medicaid program, again, that was not moved forward, but that we certainly will work to bring back and to explore further. Similarly, lots and lots of state Medicaid programs are looking at how we can make better use of community health workers, who are those kind of navigators and connectors, if you will, for people and the various supports and services that are available. And so that, again, is something we'd like to continue to pursue. So one of the questions that the Senator's office asked us to speak to is, so how, if we had been successful in advancing Medicaid expansion in our state through expanding the Badger Care program, what does that mean for people's health? How would that have helped us address health disparities? And what I'll say to that in general is, first, let's remember we remain one of 12 states in the country that has not stepped in and fully expanded our Medicaid program. So it is a dwindling number of states that we are a part of. One of the ways to think about how expanding Badger Care and Medicaid generally helps to address disparities is, at a bare minimum, we have to make sure that everybody across our state has access to basic healthcare services. And that includes basic mental health and substance use disorder treatment services. There is a raft of evidence out there that when people have access to affordable healthcare coverage, for example, through the Medicaid program, they are more likely to seek care for their chronic conditions, which are very, very common, right? They are more likely to maintain good health. They are able to address health issues that come up before they get to a crisis point where those health conditions are more expensive to address, more disruptive to the person and their family experiencing them, taking them out of the workforce, right? If they end up with some chronic illness that is truly disabling. And so for all of those reasons, that is why we continue to believe that Wisconsin should join the ranks of the other states that have already expanded Medicaid and really take advantage of being able to extend this good basic eligibility for healthcare coverage to everyone in our state who could be eligible for it. In addition, I know we spent quite a bit of time during the budget process talking about the significant financial advantage that would come to the taxpayers of Wisconsin were we to extend Medicaid. And the reason for that is that under provisions in the Affordable Care Act, the federal government pays a higher share of every Medicaid dollar as we move along to expand the Medicaid program. So we are going to continue to advocate for this kind of a change, and we'll welcome some feedback and some dialogue about how we can bring other people into the discussion. I was also asked to speak to the changes that we recommended to birth to 3 eligibility in the governor's budget, and this is really an important and a very timely question. So what we know is that children who are exposed to lead, either because they live in a home with lead-based paint, as so many children do if they live in an older home anywhere in our state. In addition, children who may be exposed to lead due to lead service lines that carry water into where they live. All of those things can cause children to experience learning delays, including at a very early age. And we all know, we all have heard about the research that talks about the first 1,000 days of life being so critical in terms of making sure that kids have a really, really strong start. And so what we had proposed was actually raising the eligibility level for the Birth to 3 program so that children who were at a slightly lower level of lead exposure would be able to have access to Birth to 3 services. The reason for that is, why should we wait until kids have that most extreme level of lead exposure before we offer them the basic services that we know can support their learning and their success in school, and obviously moving on, success in life. This also is clearly a health equity strategy. We know, based on the 2019 data that we have about children who were tested for lead, among those children who were tested, Black children were 4.5 times more likely to show up as having elevated levels of lead exposure. Asian children had 2 times greater odds than white children, and Hispanic children had almost 2 times, 1.8 times greater odds. And again, that ties directly to where kids and families live, and it also ties to the challenges we have with lead service lines in terms of lead and water. And so we continue to believe that continuing to look at how we can make smart investments in both the services that kids need if they are exposed to lead, but also in prevention. Lead poisoning is completely preventable if we can have children living in safe homes with water that's coming in not through lead laterals. We have no lead poisoning and no children exposed to lead in our state. And I think that should be something that we all can find ways to get behind and see what we can do to be protecting, really truly the most vulnerable people in our state, which are our youngest children. So with all of that being said, knowing that these were a number of the proposals that Governor Evers advanced that the legislature either chose not to move forward with or moved forward with in a very modified fashion, the question becomes, so what else can we be doing and what else are we doing to really advance equity in the work of our department? And here I would lift up a couple of things that we think are really just exciting developments. First, one of the things I should have mentioned is that the governor recommended that all agencies have a leadership position dedicated to diversity, equity, and inclusion. Wisconsin state government is an enormous employer in our state. We at the Department of Health Services employ 6,000 people. If we were a 6,000 person private sector company, we would absolutely be prioritizing diversity, equity, inclusion, and belonging in our workplace. If we are going to compete for this very precious pool of talent that we have in our state, if we're going to attract more people into our state to come and work here and stay here and raise families here, we have to be a 21st century employer, like every other employer has to be a 21st century employer. And so for us, in addition to that core mission of wanting to be able to continue to hire people to get the good work done on behalf of the people of our state, we also have a mission to protect and promote health and safety for all people in our state, not just for some people, not just for some parts of our state, all people in our state. And so in order to meet both of those missions, we created the Office of Health Equity. And the goals, the twin goals of our Office of Health Equity really are to ensure that we are an employer that welcomes all people, all points of view, all backgrounds, to make sure that the people who do the work here at the state Department of Health Services are fully representative of the communities and the people that we serve. In addition, we know that if we are going to achieve that mission of protecting and promoting health and safety for all people in our state, we have to know where we have gaps between healthiest and least healthy, where people have access to services, where they don't, and we have to be making intentional steps to address and close those gaps. And so doing that work consistently across such a diverse and complex agency requires centralized leadership and the ability to really offer some, if you will, internal consulting and technical assistance to our teams. And so both of those things will be work that our Office of Health Equity is leading. In addition, just to call out one small additional programmatic set of achievements, I mentioned obviously the challenges at the top with the differences between Black and white maternal mortality and infant mortality. So what can we do while we are continuing to build legislative support for the kinds of proposals that the governor did advance? One of those things is within our maternal and child health program in our Division of Public Health, we are looking at ways that we can be advancing good preventive strategies that promote healthy birth outcomes. So smoking cessation, good access to behavioral health services, even things like maternal mortality review processes so that we understand when a woman dies in childbirth or shortly thereafter, what happened, what were the intervention opportunities that we missed. And so we are continuing to use the staff, the resources, the partnerships that we have with so many healthcare providers, public health leaders, community leaders all around the state to really learn and to make the programmatic changes that we can. In addition, under the heading of what else can we do with the opportunity that we have in front of us, what else can we do with the leadership that we have from Governor Evers and the support that we have across the administration, very early on, the governor issued Executive Order 17 in March 2019, which created the Governor's Health Equity Council. So that is a council that really is focused, again, in that broad array of how do we identify and address health disparities. So both how long do people live, how healthy are they while they're alive, what access do they have to the conditions, the supports, the services that help them achieve their best health. So we have a council that's been convened of 34 people, including the governor and the lieutenant governor, who participate quite actively, and healthcare representatives, community representatives, people with lived experience, tribal representatives, led by Gina Green Harris out of UW-Madison and our own Dr. Michelle Robinson, who is our director of the Office of Health Equity. And the goal of this council, as I said, is to really get our arms around what is a set of policy recommendations, practice recommendations, programmatic changes that particularly the Department of Health Services can advance given our kind of central role in promoting health, but also to think more broadly than that about, again, what are the roles of the employment sector? What are the roles of environmental factors? What are other circumstances in housing and other kinds of community conditions that roll up to health? And how can we be making sure that we close gaps in opportunity and really make it possible for people to live long and healthy lives all across our state? So there will be more to come from the Governor's Health Equity Council, but we're excited to see their recommendations. And in addition, we fully imagine that those recommendations will feed into some of the prioritization that we do as we think ahead to the next biennial budget. They'll feed into some of those existing programmatic and operational changes that we can make as we move along here in our work, kind of, in between state budget cycles. If I can shift gears just briefly to talk just a little bit about the COVID response and kind of where we are. So I think At the top line, you all are seeing that the good news is that cases are continuing to decline, which is fantastic news. That said, we still have far more cases being reported every day than we did, say, last, spring and summer of 2021, when we really saw the deepest declines in overall cases. So we are eager to get back to that point. We are seeing hospitalizations come down, and that is a very, very good sign. That said, from the perspective of how has the pandemic affected the Black community in our state, how has it affected other members of racial and ethnic minority groups, that is a story of very stark differences. So we have some, I think, really powerful data on our website, and I know there's a lot of COVID data on our website, but if you haven't gone to look at the race and ethnicity tab in our COVID data section, I would really commend that to your attention. And what you'll see there is that in Wisconsin, just to take our own immediate example, Black residents have contracted COVID at a rate that is 1.2 times higher than white residents. Black residents have been hospitalized at a rate that is 1.8 times higher than white residents, and Black residents have died from COVID at a rate that is just a little bit more than 1 time greater than white residents. And similar disparities exist in other racial and ethnic minority populations. We also know that when it comes to the COVID-19 vaccines, the vaccines are safe, they are effective, they were tested thoroughly across a very diverse group of participants who participated in those clinical trials. We still are at a place where Black residents in our state are about 30% less likely to be vaccinated as compared to white residents, and our Latinx residents are about 9/10 as likely, almost 1 time less likely to be vaccinated as compared to white residents. So those gaps are closing. You may have seen some press coverage lately about that, and that is true. That's good news that the disparities are closing, but they remain. And so I think this is a thing that I would love to get your feedback on, as far as what are you seeing resonate, as far as messages among constituents that you're hearing from, regardless of the part of the state that you may represent. What we are doing to continue to address those gaps is, I would say, kind of falls under the category of a blend of universal strategies, meaning how do we make as much access available to everyone, and also focused strategies, because we know that just making access available isn't going to work when we have historical distrust of the healthcare community for very understandable and unfortunately well-documented reasons. So an example of that universal strategy would be that we have hundreds of community testing locations across our state, hundreds of places where people can access COVID-19 vaccines. Just in the testing world alone, we have 80% of the public school districts all across our state who participate in the state-sponsored COVID testing program. We ran 122,000 tests in our public schools just in the month of January. So that is a way that we are ensuring good open access to testing for school kids, for teachers, and for community members all across our state. In the world of vaccination, as I mentioned, we've had tremendous partnerships, especially with pharmacies across our state, who really have become good points of access for vaccination as well as for testing. In addition, we have lots and lots of community-based vaccination efforts. But again, all of that access is getting us, so far anyway, the results we've gotten. So what else are we doing? What else can we do? We have some grant funds through the CDC that we have been devoting to outreach grants to community-based organizations. So we have a pool of an initial about 101 grantees who represented all parts of the state, who came to us with projects about how to do door-to-door outreach and neighborhood canvassing, targeted social media campaigns, one-on-one, conversations and opportunities to really raise awareness of COVID vaccine opportunities, boost confidence in the safety of the vaccine. Of those 101 grantees, about 72% of the projects were really focused on reaching whether it was Black populations in our state or members of other racial and ethnic minority groups. So really a good distribution and a good way to emphasize how do we do better outreach using community partners who are trusted, who are known, who are the community organizations that folks in those communities know and trust and are going to rely upon. We now have a second round of those grants that's gone out to 135 total grantees. And again, we are at about 67% of those projects who will be serving, in this case, specifically African American and Black populations across our state. So we're going to continue to work on that outreach. We're going to continue to adopt that kind of universal as well as focused strategy, and would really welcome your help, your support, your feedback for how we can continue to make information about COVID vaccination as available as possible. It continues to be life-saving. It continues to be the best way to prevent the most serious outcomes from COVID, that being hospitalization and death. And again, we are seeing the cases go in the right direction. We are not out of the woods yet. Vaccination remains important. I'll just touch on two other vaccination notes. So vaccination. So the next thing coming in COVID vaccination is we do expect eligibility, at least the emergency use authorization next week, probably, for children under the age of 5. So for parents of very young children who have been really eager to see how they can be protected from COVID, that day is coming. That said, we know that we continue to trail in terms of vaccination rates, even for kids 5 to 11, as compared to where we are with the 12 and up. And so this is another case where working with pediatricians, working with trusted community partners, working with trusted voices that folks listen to, we want to be sharing that information, helping people understand how the vaccines were tested, what we know about their safety, what we know about their effectiveness. So we could really use your help in further distributing some of those messages. And then just a little bit ago, an hour or two ago, we also put out a joint press release with the Wisconsin chapter of the American Academy of Pediatrics, really encouraging parents to get their children caught up on their other childhood vaccinations. So as kids have been not going to the doctor as much due to COVID concerns and COVID precautions, we have seen that children have fallen behind in their regular vaccinations for things like chickenpox and measles and whooping cough and things that can make children really very sick that we just don't hear a lot about anymore, thankfully, in our state, because we have such a high degree of kids who are up to date with those vaccinations. So now's a really good time to be promoting a message of just having kids be healthy and safe and well protected from all manner of bugs that are out there, and would really welcome your help in lifting up that message as well. Okay, so finally, and I might say finally, and maybe most important, Senator Johnson's office asked just a really powerful question, which is Wisconsin has been for many years ranked as the worst place in America to raise a Black child. Can you help us understand more about why Wisconsin sees such disparities in outcomes for Black families, which is, honestly, that is the topic of many, many, many discussions like this that we could and should be having. So I appreciate the chance to share some thoughts about this. What I want to do in humility is offer a perspective from the discipline of public health. Right? There are many ways to answer that question. What I feel qualified to share is some insights about what does the science and the discipline of public health tell us about how we answer that question. And it really gets back to looking at all the drivers that create the opportunity for people to live a healthy, a successful life with a lot of safety and well-being and economic security and good physical and mental health, or the absence of those things. And I think the purpose of showing you this graphic is to show you that what we have learned over decades and decades of research is that it isn't all about healthcare access and quality, right? That promotes or that allows us to live long and healthy lives. Sure, that's part of it. But so is having good opportunity to seek good education and advance in your education. So is having a job that pays you enough money that you can support your family, that you can live in a safe home or a safe apartment in a safe neighborhood, drive a car that works and is going to, get you from point A to point B. So is living in a neighborhood with green space, with parks, with sidewalks, with the ability to walk places so you're not always having to be in your car. So is living in a neighborhood that is free from gun violence, that is free from interpersonal violence. So is, on the bottom of the circle there, having a good network of social supports and community, faith community, neighborhood connections, friends and family who care about you and will support you. So all those things contribute to the opportunity to live a long and healthy life. And what we see in the little boxes, which I know are kind of an eye test probably on the screen, is that due to decades and decades of policy choices and the ways that policies were carried out, Black people in our state and Black people in our country have not had, stating the obvious, the same opportunity to advance in their education, to have the same kind of employment opportunity, to have the same opportunity for mortgage lending and housing supports, to have the same access to healthcare and to healthcare providers who look like them, who come from similar life circumstances, as have white people. And so that is, those factors together, all of those factors together contribute to are a part of, I won't say they are the total answer, but they are a part of the answer to the question of why do we continue to see so many gaps and so many disparities for Black people in our state? What do we do about it? The answer to what we do about it is this whole discussion that you all have been having today. The answer to what we do about it is that we have to intervene and make equally deliberate policy choices all around that same wheel, if you will, of contributing factors, because just focusing on one thing by itself, healthcare access, for example, or employment, and in another case, if we don't do the rest of it, we will not close the gaps. We will not address all of the conditions that need to be addressed.
I know you talked in your piece, Secretary, about infant mortality and how important that is, especially when we look at infant mortality among Black babies and how our babies are dying before their first birthday at a rate of 30% above the national average. I'm wondering if you could talk a little bit about the importance of our PNCCs and their relationship to helping to deal with infant mortality.
Prenatal care coordination works, right? So access to good prenatal care is a key part of making sure that people can have a healthy birth outcome. In studies that have been done of prenatal care coordination, when it's done right and done effectively, it leads to fewer low birth weight babies and fewer preterm births. And those are the number 1 and 2 contributing factors to premature infant mortality. And it also can lead to less time spent by newborns in neonatal intensive care units. Again, all of that is really great stuff. What we need to make sure as we continue to redesign and improve this program is, first of all, that people who need access to it can get access to it. The Medicaid program today pays for the prenatal care and the labor and delivery and postpartum care for about 50% of all the births that occur in the state of Wisconsin. So we as a state have a major stake in certainly healthy birth outcomes. We want to make sure every baby has its very best opportunity to start life healthy. We as a state Medicaid program have a huge role to play in making sure that we can support that work as effectively as we can. So what we are doing to both strengthen the program on a go-forward basis, as well as address some of the concerns that we all have with making sure we have really good program integrity, is first of all, really improving the way that we enroll providers in the program, taking a fresh look at the standards and the qualifications that we ask people to meet. We also are working to make sure that on the sort of claims processing end, that we have all of those sort of structures tightened up so that we make sure that the bills that should get paid are getting paid, the bills that shouldn't get paid are not getting paid. We also are doing another round of outreach to Medicaid members. We know that where we've got potentially a very small subset of providers that are doing some marketing and some outreach that is not appropriate, we want to address that on the provider side, and we want to make sure that we are addressing it with our Medicaid members. And then finally, we also want to be making sure that as we look at the ways that prenatal care coordination programs are connecting people to the prenatal care that they need, the community supports and services that they need, it kind of loops back to that idea of a community health benefit in a sense, making sure that people have access to everything that they need to help the pregnant person be as healthy, as safe, as well cared for as they can be all throughout their pregnancy. That is a key part of making sure that we continue to close that gap that persists, unfortunately, in our state between Black infant mortality and white infant mortality.